Alright, so we're now recording. This is going to be the first unit for section 2. So starting off with ophthalmology, does anyone want to vote to start the lecture? Everyone's raising their hands. The ayes have it. Yes? No? Okay. Okay. So let's go through our ocular pharmacology. So you're going to find that a lot of these drugs are going to be topically administered. However, we're going to find some instances where you still need to use systemic therapy as the case may be. We'll talk about a few of those examples moving forward. But let's look at the application of drugs to the eye or in the eye, around the eye. So most often, where are we applying drugs to? Basically on the eye, right? So topically administered drugs, again, you're going to find that they are working very locally. What's the benefit of working locally like that? You limit a lot of side effects. Now, do you limit all systemic side effects from using topical ocular therapy? We're going to find that's not the case. We're going to find out why in just a few minutes here. Certainly, there are other means of administering medications in and around the eye. So, for instance, the subconjunctival route. Again, if you have a weird thing with like needles going into eyes, I apologize. But things like subconjunctival route, you may see some direct injections there. Obviously, this is a pretty protected site. You want to keep this as sterile as possible. So, a lot of these things need to be done in a sterile field because of the fact that it can be at risk for getting infections, and obviously, you don't want to give an infection to your patient. But there are other ones as well, retrobulbar, etc. Okay, but again, the majority of drugs we're talking about here, because again, we're focusing more on like family practice, urgent care sort of medicine here. We're going to focus mainly just on topical therapy. When I say topical, I just mean on the eye. Okay, so again, you can see some of the different patterns here as far as, kind of trends amongst the different routes. Again, we're going to be mainly focusing just on the topical route here. Now, as far as things like the kinetics are going to be a little different than what we would see with something like, dermal absorption, which we covered derm already, correct? Did we cover derm? What did we cover last time? ENT, we covered ENT, I'm sorry. We've not done derm yet, but we will get to derm at some point. But you're going to find that the absorption is a lot different, right? Because if you had to imagine, remember when we talked about Fick's law, we talked about passive absorption of things? What were some of the features that kind of prevented drugs from being absorbed very easily? Thickness of the membrane, right? So again, if you're applying something like, say, to the soles of your feet, pretty thick skin versus the eye, very thin membranes, you're going to find absorption happens a little bit better as the case may be. Other things, though, it's very convenient to use the topical route. You're going to find that it's also pretty safe for the most part, but probably infection is going to be one of the biggest things you're going to be advising your patient about, educating them how to properly administer these medications here, okay? There are some other ways that this can be administered. There even have certain dosage forms as implants. You can actually have an implant put directly into the globe of the eye. So for instance, if you need something like a very long-lasting, long-acting sort of medication, there's a good example in Ganciclovir. Here's an example of what one of these devices might look like. The drug would be impregnated within these little cells here, and then it would kind of slowly leach out over time. But most of the drugs we're giving are going to be solutions, right? So how do you dose a drug that comes as a solution in the eye? Just milligrams, micrograms. Solution, yeah, drops are going to be the most common way, right? Because again, that's a liquid, it's not very viscous. So using it in drops is the typical dosage that you would use for a suspension, right? On the other hand, though, just like you've encountered, we'll have things like gels and ointments. How would you dose that? Yeah, in a ribbon. So you apply a ribbon, but how do you quantify how big of a ribbon? Whatever it takes to wrap around your neck and tighten it about. Now, no, you typically do centimeters or inches, things like that. So if you ever see a half inch, an inch, anything like that, that's what we're referring to basically is the dose you're going to administer. There's not a lot of drugs that you dose based in length like that. Certainly, like if you ever use like nitro paste on a patient, that's another one where you'd use length as a means of dosage. We'll talk about that in cardio a little bit later on, though. But and again, the things you're going to find is that the more time the drug's going to spend within the cul-de-sac, the more absorption you're going to have, the better acting the drug's going to be, right? So which do you think is going to have a better time sticking around in the eye, a solution or something like an ointment? An ointment, why is that? Yeah, it's not very runny, right? So again, if you imagine just like, tears running out of your eyes, like if it's something that's thicker, like an ointment or something, it's going to be able to stick around for a lot longer, in which case you're going to find there's some drawbacks to using gels versus solutions, but we'll look at that in just a few moments here. Anyway, so looking at absorption, as we mentioned, the rate and extent can be dependent on how long the drug is actually there within the cul-de-sac. We'll talk about ways we can actually increase that retention time. We'll talk about it a little bit later. Certainly nasolacrimal drainage is going to be the big thing we're worried about when it especially comes to side effects. Okay, so again, if we can limit that drainage, we're going to find that drug can stick around for longer, can work better for a longer period of time there. Certainly things like diffusion across the cornea can be important here. Things like protein binding will also be playing a role, just like it does anywhere else in the body, as you'll see. And again, we mentioned that by changing the formulation, by changing it to something thicker, maybe less runny, you're going to find that it can increase that time, that contact. There's even some other things we can do, like things like blocking nasolacrimal drainage. You can do things like cauterization or plugs you can actually apply that can also help you keep drugs around for longer. So looking at this, you're going to find that the nasolacrimal drainage is going to account for the majority of the systemic absorption that happens here. Again, we'll talk about some very specific examples where this is much more of concern for certain patients. But the big thing here is just going to avoid that first pass metabolism. When I say that, what does that mean? Yeah, it's going to get absorbed through the venous drainage essentially before it ever actually gets to the liver, like you see with like GI absorption of medications there. So that means even though it may not be a ton of drug that's there, you're going to find that you still are going to have more absorption of it percentage-wise as opposed to if it was going orally, right? And again, that's going to lead to these systemic side effects we're talking about a little bit later on. Now, you can have some absorption transcorneally, and sometimes that's good, especially if the infection is actually within the eye itself. However, you're going to find it's going to take some time for that to occur, so that's that lag time. So that's why certain drugs may not be effective immediately. It may take a little bit of time to actually cross over. And again, that's governed by that fixed law, where we mentioned that the actual cornea itself, pretty thin. Things are going to be able to cross relatively easily compared to something thicker like the skin. Again, bigger surface area also is going to increase our flux here. And then what was the other thing we could change? So we said thickness of the membranes, the surface area. What's something else we could change? Yeah, the concentration gradient, right? So if I apply a bigger concentration of the drug, so I increase the percentage, say from say 0.2 to 0.3%, you may be able to get some better flux there. The other thing is going to be whether the drug itself is actually going to be lipophilic and can cross on its own, right? So again, you're going to find that some drugs, lipophilicity is going to be important because that's going to be dictating what kind of side effects we're going to be seeing with it, as we'll see in just a little bit. Anyway, as far as distribution goes, once you have things like nasolacrimal drainage occur, distribution amongst the body is not really going to change if I was giving the drug IV, GI, anything like that once it's absorbed. However, some drugs, kind of interestingly enough, can accumulate within the eye. So here's an old school antimicrobial called chloroquine that actually forms a bullseye lesion that occurs there. So you can actually see that on exam. We don't use this drug very often, but that's something they used to use back in the day. It's kind of interesting. Some drugs actually have a little bit of metabolism that occurs in the eye, in which case you may find actually some prodrugs, which prodrug is what? It's when it steps up from the amateur drug league. I don't make that joke all the time, but it's when you get it's inactive in its parent form, but then when it gets metabolized, it is in the active drug. So examples like this would be something like dipivefrin gets turned into epinephrine, and then things like latanoprost get turned over to prostaglandin F2 alpha. And again, these specific examples are not important. Just know a little bit of metabolism does occur within the eye, and then once things are systemically absorbed, they'll undergo normal hepatic or renal elimination, just like it would if you were to give it IV, PO, or any other route. Okay, so first off, let's talk about antimicrobials. I'm sure everyone's very happy to be done with antibiotics, but guess what? They're going to come back again and again because, again, infectious disease is a very common reason for people to present to you, right? Now, certainly, we're looking at periocular infections. You can kind of divvy them up based on whether they're preseptal or postseptal infections, especially things like orbital cellulitis can be presenting, and what type of antibiotics you're going to use can be dependent on kind of how involved the infection actually is. And of course, the eyes, very important. You probably want to keep your patient seeing, correct? Right, anything affecting the senses you probably want to keep intact. In this case here, you may be more likely to use things like systemic therapy. So the more involved the disease is, the sicker the patient looks when they come in, the more likely you are to be using systemic therapy. So it's not uncommon for someone who come in, whoever the provider is, makes a diagnosis of, say, an orbital cellulitis, they will get IV antibiotics rather than relying on something more topically administered. But a preseptal thing, if again it's very at surface level, you can probably treat it with some of the antibiotics we're going to talk about today. So again, I'm only going to talk about the topical versions for the moment. But anyway, so as I mentioned, the route will oftentimes depend on other patient specifics, like the clinical setting. Was there any kind of preceding trauma? Was there some sort of puncture or anything like that may be influencing this? The immunocompromised state. Why do you think this matters? So I have a patient who has, say, they have AIDS. They have a CD4 count of 0. Sometimes you'll see patients like that have a very poor immune system. Do you think they need just topical therapy? Do you think they would want more systemic therapy? Why is that? Yeah, you're just worried about that patient not being able to fight off that infection. So in case it does get more involved, you want to give them something systemically to fight that off, right? So again, these are things you want to consider when you're looking at these types of patients, especially if someone comes in who's immunocompromised, they have a fungal infection. Like, that's not a good sign. That's something that most individuals can fight off, but you may need to use something more systemic in order to treat that. I'll show you some examples of that a little bit later on. Anyway, so looking at ocular antimicrobials, you're going to find that most often, what is causing these sorts of infections? And viruses are going to be the most common thing. But of course, antimicrobial spectra, bacteria can be involved here, but it's going to change over time. And so we're going to find, especially, changes like, H flu might go down due to things like vaccination, right? Again, most of the time, if you have a true blue, like really involved ocular infection, you're probably going to want systemic therapy, either oral or parenteral agents, depending on, how sick the patient is. But again, with these small, mild peripheral infections, which we're going to focus on today, you're going to be finding that we like to use topical therapy because, one, that's going to limit the systemic bioavailability. You're also going to find we can use a lot higher concentrations when we're using something topically because it is not getting absorbed to a high amount. That will overcome things like resistance. You're going to find that we can use drugs that, while systemically may be resistant, the bug may be resistant to it, we can actually get away with topical therapy because, again, we can drive up that dose pretty significantly there. Okay. However, one of the drawbacks with ocular therapy is they typically require pretty frequent dosing, right? So again, you're thinking at least Q8 to Q6 hour sort of dosing. And again, what happens as a drug gets more and more frequently, needs to be more frequently administered for your patient? And compliance is going to go down, right? They're going to be like, oh, I don't want to have that eyedropper again. Like, it's just a pain in the butt. I'm not going to do that, right? So compliance is going to go down because of that. Typically, we're going to be using pretty broad spectrum antibiotics here. And again, we're using pretty high concentrations, so we don't really see resistance being a problem. And typically, you do not culture these unless there is a specific indication. Like, so if you think it was an immunocompromised patient, you think it's something that maybe not something abnormal, something you wouldn't normally see in a patient with a good immune system, that could be a case. But typically, just topical therapy, no need to culture these kind of. Now, looking at conjunctivitis, certainly there's lots of different varieties of it, and I'll show you some indications on an upcoming slide. But just know that we're kind of just talking about conjunctivitis kind of as a whole here, because the therapy doesn't really change all that much. Now, again, I mentioned viruses are going to be very common, but certainly there can be other things like allergies, could be related to environmental factors. Contact lenses are a big one. What bug do you normally think about with contact lenses? Pseudomonas, right? It's going to be important. It might come up on a test. I'm sure it's already come up on a test for you. It may come up again, right? However, other things can be occurring here. So I mentioned infectious pathogens and things like Neisseria, Haemophilus. Wide variety of things could be causing infection here, right? So again, this is why we shoot for broad spectrum antibiotics for the most part. And obviously, we like to eradicate the infection and try to prevent any kind of complications from occurring here. Now, looking at this slide, again, don't get bogged down by the indications. Just know that you're going to find that some of these are going to be better suited for certain types of infections than others. We'll talk about specific use cases in a little bit. And again, just as long as you know that, okay, well, I would use this antibiotic for conjunctivitis, I think you're probably going to be good for at least my class, right? Here are the examples of drugs we're going to be using here. And again, here are the formulations. Again, it's not important you memorize the formulation. You can look that up when you're doing the dosing, but I'd rather you know which one would be appropriate for my patient based on specific circumstances, right? So we'll talk about some examples of that in a moment as well. You've already seen, so I'm not going to have to belabor the points of things like mechanisms of action, etc. We will talk about specific side effects, though, because that's going to be more important for when we're using these things topically within the eye itself. Now, the most common one you're going to find, as far from a macrolide standpoint, is going to be erythromycin. Azithromycin also has formulations available as well. However, erythromycin is a lot cheaper. It's a lot more widely available. Comes as an ointment. Very easy to use, and a lot of people use this pretty frequently. Now, again, how do macrolides work? Protein synthesis inhibitor, right? That's all you said. I would consider that correct for our purposes here. Now, again, as far as adverse reactions go, what do you think is going to be a common adverse reaction for any drug I put in the eye? Irritation, right? Pain, irritation. Obviously, hypersensitivity is a risk as well. We'll talk about why that may be more important a little bit later. But yes, hypersensitivity, eye irritation are going to be something you see with any of these agents, right? Now, again, what is specific about the eye that we, some of the things we look at when we're actually making these formulations, we're going to be very careful with things like the tonicity of the drug. We're looking at things like, the pH of the drug, because we know the eyes are so sensitive, which again, going back to ENT, what was the thing between ophthalmic preparations and otic preparations? The eye can go in the ear because the ear is very insensitive from that standpoint, but the ear, could you go to the eye? No, because it's just not balanced for that, right? So again, everyone can have some irritation with this, even though it is specifically formulated for the eye. Now, just to show you the difference here, like erythromycin is going to be an ointment that you're going to be dosing based on, like, say, ½ inch versus azithromycin, maybe a drop. Now, notice that you're going to find that the duration, the frequency can differ pretty widely based on the drug itself. For instance, azithromycin, pretty long half-life, and only has to be used, say, maybe, twice daily, and then you actually go down to a daily, right? So it's not super common. Very frequently, you have to give it quite often. So for instance, with erythromycin, maybe giving it anywhere between 2 to 6 times per day, depending on the severity of infection, right? So again, you're going to be kind of looking at it and be like, it looks pretty bad. Let's go ahead and do 4 times a day. Let's do 6 times a day. But again, the more frequently you give it, the less compliant the patient is likely to be. Okay. Now, most of the time when you have a patient come in with conjunctivitis, you say you're not going to culture for it. So are you going to 100% of the time be treating patients with true bacterial conjunctivitis? A lot of times you're not, right? But you're still going to give them therapy for it. So this is one of those cases where I oftentimes say, unless you really think it's bacterial, don't give them anything. This is one of those cases where it probably doesn't really matter, right? So for instance, when someone comes in with conjunctivitis, they probably want something done about that eye irritation, the pain they're experiencing. Erythromycin is pretty good from that standpoint. That's why ointments are very nice, because they have a good soothing effect on the eye. And so even if it's not truly bacterial, you're probably not going to be harming the patient by administering this. However, it's not the case for a lot of other indications we'll see, especially with systemic antibiotics. But for the eye, this is probably not going to be a problem here. Now, erythromycin, as I mentioned, is a lot cheaper. Used much more commonly. Azithromycin can be used if for whatever reason you thought they might have a resistant infection, or erythromycin may not be a good option for them. Azithromycin can be used, but is going to be considerably more expensive. But if you thought compliance was a big problem, maybe this is a better option for your patient. Just really depends. Okay. Up next, we have trimethoprim and polymyxin B. Anyone remember how trimethoprim works? Yeah, so blocking dihydrofolic acid over to tetrahydrofolate. Remember that it blocks folate utilization, folate production within the bacterial cell. That's enough detail for our purposes, right? Now again, you're going to trimethoprim working on one mechanism, and then polymyxin B. Anyone remember how that one worked? Yeah, basically disrupt the cell membrane pretty significantly by kind of puncturing yourself through the cell wall there. So again, using synergistic mechanisms to get better bacterial kill for those patients, right? Again, just another example, bacterial conjunctivitis is the main indication here. No specific adverse effects to really note besides the irritation. And again, as far as drug interactions go, do you think there's a lot of drug interactions that happen with using these topical products? Not frequently, because again, a lot of systemic absorption is not happening here, so they can't really have a chance to interact with other drugs. There'll be some exceptions to that we'll talk about a little bit later on, but at least with these antibiotics, not a lot of drug interactions to consider. We also have sulfacetamide, and so this is going to be, again, working on the same place that sulfamethoxazole was working, right? So again, this would be a product by itself being used to again, block that production of DHF in those bacterial cells. Again, used for bacterial conjunctivitis. They have solutions or ointments, again, depending on the patient. You may choose one versus the other. And this one would be, you want to be careful with this one. If you had a patient who had a Bactrim allergy, or you knew they had a sulfonamide allergy, say sulfa drugs, this is not something you want to administer to them, because it will have a local reaction when applied to the eye. So that would be one case where, if I put on the test question and said patient was coming in, you diagnosed with bacterial conjunctivitis, they had a history of sulfa allergy, history anaphylaxis, you'd want to avoid this one. There'll be one say, hey, I don't want to use this. This is contraindicated in this patient. Next, a Bacitracin ointment. So this is, again, one we use almost exclusively topically because it is pretty toxic when actually administered systemically, so we don't really use it that way. But certainly you think about like your neosporins, you're going to find some Bacitracin in there. It's good for like a topical anti-infective. We also use it in the eye as well fairly commonly. And again, this one is an ointment. Apply, say, ½ inch, 1 to 3 times a day. So nothing really kind of delineating these from any of the other ones from that standpoint. Where it does get a little bit more complicated is with the fluoroquinolones. Anyone remember how those work? Yeah, DNA gyrase gets inhibited. You can't have those single strand, the unwinding of the DNA and the rewinding of it after the fact. Good. So we have several that will fall into this category. We have ciprofloxacin. We have ofloxacin. Anyone know the relationship between O and levofloxacin? Had to guess? Isomer, yeah. No, absolutely, yeah. So it's the enantiomer of ofloxacin. So levofloxacin is just the left-handed version of ofloxacin, basically, right? So we'd call ofloxacin a what kind of mixture? Racemic mixture, yeah, absolutely. So again, not super important for your clinical purposes. Just know that if you see one that looks more expensive and has a levo or a dextro on the front of it, that's probably why it's more expensive, because it was kind of a drug they brought out later on. And again, the parent drug may work just as well. So we use a lot of ofloxacin for our patients over at Nemours quite frequently, so we use often enough. Now, this is not something you want to use for every patient, right? So I can give whoever walks through the door, I can give them erythromycin ointment, give them polymyxin B/trimethoprim. No one's really going to have any issues with that. However, fluoroquinolones, I probably want to hold back and reserve that one for specific cases, right? So specifically, if I have things like corneal ulcers that have been developing, this is going to be a better indication for that. Or if I'm ever thinking, what bug? Pseudomonas, right? So again, if I had someone who came in with a history of contact lens use and they had this bacterial conjunctivitis, these might be a better option for those patients, right? Now, again, these are going to be a lot more expensive than something like a typical erythromycin ointment, but because it covers Pseudomonas, that's why we want to hold it back and use it for these very specific instances, right? As far as adverse effects go, only thing different here, ciprofloxacin typically has a white precipitate that will form, and again, patients probably have some drainage and some purulent material they're producing anyway. Just let them know that. Let them know beforehand that, hey, if you see this white sort of powder that kind of develops around the eye, that's normal. That's just a ciprofloxacin. It's probably due to the rest of the vehicle kind of evaporating off, and that's what the drug is kind of left behind from those instances. And again, why might they have an unpleasant taste after installation? Yeah, due to that drainage, you're going to have something that's going to potentially get down to the back of the throat, and they can have that unpleasant taste there. And again, no clinical interactions. However, that's only when given ophthalmically, right? Remember, if we were to give it via the systemic route, we see there's all kinds of drug interactions, right? Yep. Anyone remember what CYP enzyme fluoroquinolones inhibit? 1A2. 1A2, fantastic, right? Remember things like, what does it do to the heart? QT prolongation, right? So again, remember all the systemic sort of things. It's not going to be applicable here when thinking ophthalmically, but just remember that's going to be a case if you were to see it systemically used. Good. And again, preferred for corneal ulcers or Pseudomonas. Again, being a gram-negative rod, fluoroquinolones typically have a very good activity against it. Even Cipro, which may have plus or minus activity against Pseudomonas when used systemically. Again, we're having much higher concentrations right there at the side of the eye, so we can get around that resistance pretty easily in this case. However, do worry about things like emerging resistance. They are more expensive, so that's why I want to be more judicious on how we're going to be applying these to our patients, right? Okay. Again, contact lens wearers, this is going to be a preferred agent for them in most cases until you kind of rule out other things. Okay, we also have our aminoglycosides. Most common ones you run into are gentamicin by far, and then you also have tobramycin. Anyone know where you do use gentamicin eye ointment frequently? Any particular subset of patient? Specific age of patient? Anyone ever seen a baby born? That goop over their eyes? That's usually gentamicin ointment that are going to be applying there. So again, we worry about, especially like vaginal deliveries, you worry about the baby picking up bacteria from mom, and so they'll actually apply gentamicin ointment to the eyes there to prevent any infection. First time my Lily was born, I was just like, oh gosh, what's wrong with her eyes? And I'm just, oh, wait a second, that's the eye ointment they put on there. That makes more sense. It just looks so goopy. You're just like, oh, hopefully they didn't pick that up from my wife. But anyway, she did not. We did, the nurses did that to her. Anyway, so aminoglycosides you typically don't want to use in most cases. Again, there are specific instances. Again, in the NICU, quite frequently there. The problem here is that this can actually cause corneal ulceration in and of itself. Not only that, but it can also cause kind of a reactive conjunctivitis that can occur here after several days of use. So with the babies, you usually just give them a one-time dose, and so that way any bacteria they may have picked up from the birth canal kind of gets wiped out initially. They don't really, you're using it prophylactically. In these cases here, we don't use it unless we have a very good indication to. And again, I don't frequently see these being used outside of that NICU sort of setting here. Okay, so then moving on, we also have a few antivirals that we can utilize. So again, if you think about someone who has just like a normal viral conjunctivitis, are we going to be giving antivirals for that? No, because it's usually things like coronaviruses, adenoviruses. Like we don't really have a good antiviral therapy against those. So in those cases, we don't really treat them with anything. That's why you can just give them some erythromycin ointment. It'll make them feel a little bit better, but you really don't have to do much in those cases there. However, if there are things like herpes zoster, if they're developing this retinitis, anything like that, these are more significant, potentially sight damaging sort of infections. These are the ones we're going to be using antivirals for. And just remember, especially if you have patients who have immunocompromisation, you may need to use more systemic therapy because, again, you're worried about that virus maybe not just staying in the eye, but could become more systemically sort of involved in those cases. So here are the ones I'm going to just point out. The ones in yellow here are the ones you're going to be using specifically as a topical ocular agent. Okay, the other ones are going to be listed here. We've covered a lot of these already. Things like acyclovir and valacyclovir. These are going to be better for patients having more kind of systemic disease, or if you're worried about them being able to fight off that infection due to immunocompromisation. That's where you want to use more systemic therapy. Again, I'm not going to belabor those points again. I want to focus just on the eyes in this case here. So two drugs, the one called trifluridine, and then we have another one called ganciclovir. And again, ganciclovir you will see used systemically for things like CMV or cytomegalovirus. You see it used a lot of immunocompromised patients, but here we have a specific case how we're going to use it within the eye. Okay, so the mechanism of action with a lot of these is try to inhibit the production of new viral DNA. And so again, a lot of these are going to be kind of false base pairs that are going to be getting incorporated into the DNA, but then they can't have any further nucleotides added on after that. So they're kind of these chain terminators. And again, once there's enough damage done to the DNA, the virus just go ahead and just kind of commits apoptosis essentially, and then it's done. Now, trifluridine or viroptic is oftentimes going to be used for herpes simplex viruses that patients develop this keratoconjunctivitis. The one thing that's kind of interesting to note here is that as far as adverse effects go, it develops this punctate keratopathy. So again, if you're using like a Woods lamp or something, you'd actually be able to see that. Again, not anything to do with the disease, but actually due to the treatment that we're administering to the patient. Okay. The other one, ganciclovir, this is again going to be getting incorporated into the viral DNA, similar mechanism, just a little bit different chemical structure here. Now this one does get used for things like herpetic keratitis and cytomegalovirus. Retinitis is going to be the most common place you'll probably see this used, and this is going to be an intravitreal injection, right? So this is going to be one of those implants we actually put directly into the eye itself, and again, that's going to be nice because it'll allow for kind of a good long-lasting release of drug over a long period of time. And again, you're using this in patients with poor immune systems, so we need that kind of long-term sort of use there. Just an example of look how you'd have the ganciclovir. Here's an actual tablet with this sort of suture tab, and this basically gets put directly into the eye itself, so it can then release and have nice local action right there within the eye itself. Again, just another form showing eye injection there. Again, please make sure I am completely sedated before ever doing something like that to me. I will probably freak out otherwise. So.
Wait.
And then, no, it is not like a water balloon or. No, unfortunately, probably like things like the movies have probably misled you as far as the actual physics of the eye. Yeah. Anyway. Moving on, the last thing to cover is going to be antifungals. We only have one antifungal that's going to be used topically within the eye. It's going to be natamicin. Again, when you see these fungal infections that occur, you want to worry about the fact that, hey, this person probably doesn't have a good immune system. You need something more systemic to fight off that infection. So I'll show you that table in just a second. But natamicin is going to be the only one we're going to be using in that case. Again, otherwise you need systemic therapy. Anyone remember any other systemic antifungals we can use for patients? Itraconazole. Fluconazole, those are all. What's the one that was like really nasty as far as amphotericin B, right? We call it amphoterable B because it has such bad side effects on the kidneys and whatnot, right? So again, those are going to be used more for systemic use because again, you're worried about not just having fungus in the eye, but elsewhere as well, right? And again, what's pretty close to the eye? The brain, right? So you worry about things kind of getting more in the CNS as well. Again, looking at this, you see the more systemic therapy. So again, you have things like amphotericin B, and more often than not, you're going to be using more systemic therapies, things like fluconazole, itraconazole. Now, some of these you'll look to see like, oh, this is an intravitreal injection. That's usually the IV form that we're actually formulating to actually inject into the eye. So again, not commercially available. I just want to focus on what you might actually have to write a prescription for one day. In this case, natamicin might be the one. And again, this is more often than not going to be something you're going to be farming out to the ophthalmologist anyway. But at least if you see a patient who's on this, you at least know what it's for, right? And again, basically just going to be trying to increase the permeability of the cell membrane, kind of disrupting it so that way the fungi is going to be able to break apart lysol's contents out. So we've seen that mechanism used before. Again, don't worry about the specific fungi this is going to be covering. Just know that it's going to be used as a topical ocular antifungal agent, right? Nothing big as far as adverse reactions go. Okay, so remember, whenever you're dealing with a patient's eyesight, you want to be checking visual acuities, right? You want to do it before and after, because again, you're looking for that delta. You're looking for that change that occurs over time, so that way you know if it's getting better. You more importantly know if it's going to be getting worse in these cases, okay? Again, before prescribing, make sure you look at their allergies. So again, if you had someone who had a sulfa allergy, or if they say I'm allergic to Bactrim, it should clue you in like, hey, maybe I don't want to use sulfacetamide for these patients, right? And again, on follow-up, make sure you're checking that visual acuity, look for any differences there as well. And obviously, if it's getting worse, consult ophthalmology, right? Now, how to administer ophthalmic medications. What's the first step? Wash your hands. That's probably how they got in the infection in the first place, if that's what you're treating. So make sure they wash their hands very well. And then other things to note, when you're having patients with ocular products, do you want them to share? No, it needs to be single. And that may sound like super obvious, like, yeah, who would be gross enough to share? People are gross enough to share. Okay, they will try to do that. So again, one person to one bottle. You don't want to be sharing the stuff around because otherwise that's how you spread cooties, right? Now again, avoid having them touch the dropper to anything, because when you do that, that's when you're going to have it maybe pick up a virus or pick up a bacteria or something, and there's any contact with the eye or areas surrounding, that's when you're going to have more infection can occur there, right? So again, what we're going to have them do is kind of pull their head back, pull the lower eyelid down, and that's going to give us a nice little reservoir there, that cul-de-sac, where you can actually administer the drug in that little pocket. Now we're going to be basically having the opposite hand's going to be holding the dropper up, and of course, you may need someone else to administer this drug, because most people's first instinct is to do what? Pull away, right? Your eyes are something you naturally just want to be protective of. So some people are worse about that than others. Some people who wear contacts their whole life, like they don't really have much of an issue with touching their eye, but other people who don't may have some issues, or kids, things like that. And again, go ahead and squeeze a dropper, usually a drop or two at a time, into the actual pocket there. Now, the next thing you want to do, I'm going to tilt our head forward and then actually push down right there over the lacrimal duct. What does that do for us? Stop the drainage, right? So again, you're going to be able to keep that drug there for longer. It's more likely to be effective, okay? So that's the big thing you're going to be doing with that. Usually hold it closed for 2 to 3 minutes or so, okay? Give them a little bit of time. Again, most patients will miss this step. They'll decide not to do that because, again, 2 to 3 minutes when you're sitting there, it probably feels like a lifetime, so they don't do that. But again, recommend they do that. Afterwards, make sure they wipe off any excess drug and then go ahead and wash their hands again, just again to prevent any further infection spread. Now, as I mentioned, drops versus ointments, what's going to be better depends on type of patient you're dealing with. So, for instance, ointments tend to be better for children, right? Why is that?
It's longer lasting, so.
Yeah, it's kind of longer lasting. It's more likely to stick around in their eye for a little bit. Even if it's something like, for instance, you think they have a bacterial conjunctivitis, you recommend some erythromycin ointment. Even if they just get it in the eyelashes because the kid's trying to fight you and move around, you're going to find that it can still make enough contact where you can actually get some benefit from it, right? So again, be nice to get it right there in that pocket. You may not be able to, depending on how non-compliant your patient is going to be with that, right? Now, again, with ointments, the other thing you have to note is if the patient needs to drive somewhere, it's probably going to have a little bit of blurry vision for the next 20 minutes or so until that ointment starts to kind of break down and dissolve a little bit. So initially, if they need to go somewhere, ointments may not be best for them in that case. Okay. And as far as gel and ointments go, the process for administering is going to be the same, except they're going to be squeezing out the ribbon of medication. And again, if you can write down a ½ inch, does that matter if it's like 0.6 inches or 0.4 inches? Nah, you're just trying to get in the area, right? So again, just kind of eyeballing it. No pun intended. It's very good in there. Anywho, in those cases, though, because it has a lot better staying power with gels and ointments, you don't need to cover the lacrimal duct at that point, right? Because the drug has enough staying power on its own. Here's a random question. Does anyone know what to do if you glue your eye shut with super glue? Acetone? Do you want to put acetone in the eyes? Ouch. May hurt. Huh? Johnson soap. Maybe no more tears. Maybe that'll work. No. Basically, what you end up doing is we either use something like you want some sort of we actually call that super glue is actually called cyanoacrylate, and so we want something that's going to be able to break down that glue. And so what we'll oftentimes use is some sort of oil-based or more kind of thick sort of viscous stuff. So we'll use something like an ocular ointment. So actually, erythromycin ointment is the number one thing we'll actually recommend. Patients come to the ER, their kids accidentally glue their eye shut. We'll have them go ahead and use that, and then just place it over the area, and that will actually help to loosen it up. Usually, it's the eyelashes that are actually stuck to the skin, and so that will help to break it down, and their eye will be free to go again, right? This is the most common thing, with the actual fingers getting glued together. You can use something like Vaseline or some kind of oil-based product is going to help to break that down and free the patient's skin. So just a little trivia there. Anyway, so with contact lenses, what should you do with the contact lenses after you suspect there's an infection? You just clean them real good, scrub them down, just pop them right back. No, you want to throw them out, right? So you can get rid of that stuff. You want them, they can resume use usually about 24 hours or so after the eye does not look inflamed anymore. There's no discharge. Give them that a little bit of a grace period. They can start to use them again. And then as far as eye makeup hate to tell you, but you're probably going to want to throw it out. So I don't know if you buy the Walmart stuff or the Ulta stuff, but just get rid of it. It's not worth reinfecting yourself. Again, huh?
Is it done?
Is it though? I don't know. Maybe. I don't know how expensive eye makeup is, but I would assume I'd rather not get an infection again. So who knows? I just buy the dollar store stuff and it works great. So anywho, any questions on the anti-infective portion of this? All right, moving forward, let's talk about. So seasonal allergies is going to be a big thing. We're seeing this quite often now. And in fact, I'm starting to see the allergens really start to kick up. I was in the hospital yesterday, and every patient coming into the ER, I think, was either there for an asthma attack, kind of showing you the allergens are in the air, or also weather changing, and then also they were there for constipation, right? Not that's related to this talk, but anyway, the allergy portion of it. A lot of go light that was going out there yesterday. But anyway, and again, when we're looking at these allergic reactions that are happening here, again, it's mostly mediated by things like your mast cells, basophils, things like that. And IgE is going to be the main immune globulin that's going to be involved with this, right? And so one of the big products, and we've already talked about antihistamines already, but histamine is going to be one of the big kind of causative components here. It's going to be causing a lot of the redness, the tearing, all these sorts of things, all kind of the portions the patient's not really liking so much, right? But again, we're seeing these reactions, we're seeing a lot of vasodilation. That's why eyes get hyperemic. We're going to be seeing swelling, redness, itching, all that good stuff is mainly going to be mediated through things like histamine, right? So we're going to be using that as our main target when we're looking at these drugs here. So again, looking at that, having histamine being released here, again, you're seeing that redness due to vasodilation and fluid leaking out due to bigger leaks in those little capillary, bigger holes that the water can go through essentially. Now, the agents we have, as far as antihistamines go, and again, when I say MCS, I'm just referring to mast cell stabilizers. That's the next class we're going to talk about. But from an eye allergy standpoint, these are going to be the most common ones you're going to be running into, are the antihistamines. One special one to note here, so we have things like azolastine, which we saw previously, I think, in the ENT section. We saw it for nasal symptoms. We have things like ketotifen. Ketotifen is actually available over the counter, which is good to note in case your patient's already been treating themselves with something. You want to be able to pick up on that when you ask them about their medication history, right? Other things I see pretty common are things like olopatadine, which is Patanol or Pataday, but any of these could be potentially seen as an antihistamine used directly in the eye. Now, again, note that this is not going to be as good from a compliance standpoint because, again, if I'm having a lot of seasonal allergies, is it frequent that just the eyes are affected? Not often, right? Because often you're going to have nasal symptoms, you're going to have eye symptoms, you're going to, all these different things. So oftentimes more systemic therapy is used, right? So I'm not going to belabor the point and talk about antihistamines systemically all over again. But, looking at things like using second generation antihistamines can be very good for helping out with a lot of these symptoms, especially if it's not just relegated to one organ system, right? Now, what are the benefits of using second generation versus first generation antihistamines? Less drowsiness, right? That's going to be the biggest thing there. And again, what are my examples of second generation antihistamines? Zyrtec, which is? Cetirizine, good. Loratadine, and then what's Allegra? Dexafenidine, right? So again, good to know your generics because, as I mentioned, on the pants, they're only going to ask you in generics because they don't want to show any kind of commercial bias or anything. So being able to recognize these is a good thing. So when you see fexofenadine, you're not like, oh gosh, I've seen that one time in Farm 1 back 2 years ago. What the heck drug was that? You know that, okay, I know it's Allegra, I know it's second generation antihistamine, I know it's going to be good for not causing sedation, X, Y, and Z, right? Anywho, these are going to be better for working for more sort of immediate symptoms here, right? Because the other class we'll talk about is called the mast cell stabilizers. And so what do you think a mast cell stabilizer does? Yeah, it inhibits the degranulation, right? It stabilizes that mast cell so it can't release things like, histamine, right? So what's the thing to note about when should you use a mast cell stabilizer? Probably before the mast cells destabilize, right? So before they have degranulated, that's when they're going to be most effective. If you've already released all that histamine, mast cell stabilizers will not really do a whole lot. That's when you need to switch over and consider using your antihistamines. So the question is a patient going to use this prophylactically? Well, it may be okay to use a mast cell stabilizer, but very frequently they're going to be using this as needed for when symptoms are occurring, in which case histamine's already been released. These are going to be better drugs to use for them, right? So either a ketotifen, olopatadine, whatever drug they want to use for those eye symptoms. The onset is much faster for this from that standpoint than you're going to see with the mast cell stabilizers. Also, give it about 2 weeks or so where you really see the full effect, see how they're going to be responding to it. And as far as adverse effects go, this makes sense based on what we know about antihistamines to begin with, right? So if you remember, what was another kind of predominant set of symptoms you saw with patients who were using antihistamines?
Constipation.
So constipation, why did you see constipation?
Because the opposite of the muscarinic receptors.
Yeah, so it's an anticholinergic, right? It was anti-muscarinic in those cases, right? So that makes sense why you end up seeing increased ocular dryness, because what do anti-muscarinics do to secretions all over the body? Dries them up, right? You're going to be dry as a bone. So because of that, that's where you're going to see ocular dryness here, right? So that's something you can link back to that mechanism of action and the fact that it's going to have effects on muscarinic receptors, right? Anyway, no big drug interactions here. And again, as we mentioned, preferred over the mast cell stabilizers predominantly. Again, you want to use the mast cell stabilizers before the degranulation has occurred. However, you're going to find that a lot of patients would have to use this more prophylactically. So they're going to be using this kind of throughout the season or whenever it is that they're expecting to have these eye symptoms. They want to be able to use it beforehand so that way. So for instance, I know I'm going to go and see my brother who has a dog, and I know the dog is going to bother my eyes, and I could take this maybe beforehand to prevent that degranulation from occurring in the first place, right? The three we have are going to include cromolyn, we have lodoxamide, and netocromel. Those are the three main mast cell stabilizers you'll see used in the eye. Again, these are used much less frequently than the ocular antihistamines, but again, it's good to know, be able to recognize these drugs when you see them in the real world. Again, you need to use them for about 2 weeks or so before you really assess for full efficacy. And again, these are not good for acute symptoms. So they're already having symptoms. These are not going to be working for them. Again, it's important to know. Again, pretty frequent dosing here. So again, not ideal from a compliance standpoint, but it's good for patients who maybe they can't tolerate antihistamines. Maybe they already have an issue with dry eyes to begin with, and then they want to use something else. This could be a good option for them in those cases. Okay, other agents, and a lot of these are over the counter, so you're going to see these pretty frequently being used, are going to be vasoconstrictor and occasionally antihistamine combination. Okay, so as a vasoconstrictor, which receptors do you think we're going to be hitting? Alpha-1 receptors are going to be the big things we see. So anyone remember a vasoconstrictor we saw for nasal use? Oxymetazoline, right, is afrin. Notice anything about the naming convention here? These are very similar sort of drugs. So you see that that Olin or Zoline sort of naming thing there. So oxymetazoline, you have tetrahydrozoline, you have nefazoline, and then another one called phenyramine, which is actually an antihistamine that will oftentimes be put with nefazoline. So it's another common one you're going to see used for over-the-counter use, right? So again, these are good because these will help with the hyperemia. They'll help to constrict those blood vessels. So that will deal with the edema. That's going to help to deal with the redness you're going to see with that, right? And so again, you're going to find that these are good for short-term use. What was the problem with using afrin long-term? Rebound congestion, right? So same thing can happen here. If you're using it too long, you have this rebound hyperemia after discontinuation. So really recommend not to use it for more than 2 weeks. It's a really good counseling point, right? So again, if their eyes are bothering, don't tell them to use it constantly. In those cases, they may be better off using something like an antihistamine by itself, right? Or if they need to, something like a mast cell stabilizer, if it's something that's going to be happening pretty consistently. Okay. Now again, with any of these over-the-counter products, it's really important to let them know, hey, if you're going to use them, that's fine, but just make sure if the symptoms are not improving over say 2 to 3 days, they need to come in and get checked out, because what could it be? A million other things, right? Could be infection, could be all sorts of things. And so this is why it's very important to make sure patients know how long they should be using over-the-counter stuff to self-treat, because oftentimes they can mask the symptoms of something more serious. So again, if something hasn't gone away in a couple of days, you probably want to get it checked out and make sure it's not infectious, etc. Questions from the first half here? All right, so continuing on, next up we have a group of NSAIDs. Now NSAIDs themselves we know to be anti-inflammatory, so you think that these could work for ocular symptoms of allergies and things like that. You're going to find we don't necessarily use them very often in that case, and in fact these are a group of drugs which you want to be somewhat cautious with using. You don't want to necessarily jump to using these that frequently. Now again, how do NSAIDs work? We've already covered ibuprofen, we've covered naproxen. How do they work? They inhibit cyclooxygenase. Well, yeah. So again, we're talking about non-selective NSAIDs, which in the large majority of NSAIDs we're talking about, they're going to be blocking cyclooxygenase 1 and 2. Again, anyone remember which one is kind of expressed all the time? It's COX-1, right? That's called constitutive because it is around all the time. COX-2 is going to be what we call inducible, right? So that's going to be when you actually have inflammation actually occurring. This is what gets upregulated in those cases. Can you please stop giggling whenever I mention cyclooxygenase? You must. I cannot have you in good conscience go out and talk to patients and giggling every time. Mr. or Mrs. PA, how does my drug work? And then you start giggling uncontrollably. I will not have that happen, okay? We're just going to keep saying it together until it stops being funny. It starts being funny again, and then continue on until it's again not funny. Anywho, yeah, so again, what does cyclooxygenase work on? What is the original kind of chemical that we're working it against, or molecule? Arachidonic acid, yes. Arachidonic acid is getting converted over into a lot of these inflammatory cytokines, right? So prostaglandins are going to be a big thing here. Prostaglandins are going to be important when we get to talking about glaucoma in just a few minutes. But yeah, so just know that yes, most of the ones we're dealing with are going to be non-selective. This will be more important in pain management a little bit later on, but they're going to work on oxygenase 1 and 2 equally. Now, a couple agents we have here, things like bromfenac, we have diclofenac. Anyone ever heard of diclofenac before, or Voltaren? What dosage forms that come in? There's actually a topical formulation called Voltaren gel that you can use as a topical NSAID. It's good for arthritis, pain, and things like that, which we'll talk about later on. But there's an ocular form as well. You have things like fluorbuprofen. You have ketorolac or ketorolac. Most people will probably say ketorolac. The actual correct pronunciation is ketorolac, but most people look at you funny if you say that. And then napafenac are the ocular NSAIDs here. Now, most frequently, we're going to be using these in the post-operative sort of setting and dealing with that post-operative inflammation. Sometimes will be used for allergic conjunctivitis, but it really needs to be reserved for patients who have failed the ocular antihistamines first, or if, say, systemic antihistamines are not appropriate for that patient. That's when you can utilize an NSAID, because it will work on the inflammatory cascade that's occurring for these allergic symptoms. However, it's not going to be great, because we're going to see there's going to be some side effects associated with it. Mainly, you're going to see things like keratitis can develop with this. It can actually raise your intraocular pressure, which is not good for who? Glaucoma patients, right? And also cause some irritation as well. So again, not the best first-line agents for allergic conjunctivitis, but good for post-operative pain, surgery. Now, there's some other agents as well we can use called glucocorticoids. We're familiar with glucocorticoids, but there's going to be some specific ones that are only used ocularly. Now, again, these are also agents you really should not be using unless you have a very good idea of why you're using them, or if you work in ophthalmology and you're very used to using these, you want to reserve these. But again, if you see patients on them, you want to know, what's going on here. But again, corticosteroids are going to be working at the very top of the inflammatory cascade, working at the site of the nucleus, right? And again, this is good because they work locally, but this is where we're going to start to see there's some bleed over, and we're going to start to see some systemic effects that can occur with use of these drugs here, right? Now, main uses we're going to have the ocular corticosteroids being used for is going to be severe ocular allergy. So again, if other NSAIDs, if the antihistamines are not working, this may be something to use as a backup. In some cases, if you have any kind of external inflammatory disease, anterior uveitis, inflammation after ocular surgery, these are all cases we're going to be using it, but very selective. And again, you probably will not be prescribing these on a regular basis unless you work in ophthalmology. And again, most of the time they're going to be applied topically. Sometimes will be intraocularly used, as the case may be. We use this a lot with some of our ophthalmologists when they're in the OR. They use a lot of dexamethasone within the eye itself. And again, working on all sites of inflammation, decreasing inflammatory cytokines from being made, decreasing the amount of white cells that are being attracted to the area, kind of work on all aspects of inflammation. Now, the reasons why we don't like to use these very frequently is one, this can actually help to accelerate cataract formation, which again, not good. This can actually help to elevate the intraocular pressure, and this is more frequently seen, especially in patients who have a history of high intraocular pressure glaucoma. Because it helps to depress the immune system. This is where we're going to see more infections occur, either viral, bacterial, as the case may be, maybe even fungal if used for a long enough period of time. And then we also worry about things like causing delayed wound healing, which we knew glucocorticoids do at a baseline, and then can also lead to corneal ulcers. So just due to the side effect profile being so nasty, we don't like to use these unless there's a really good indication, or for short courses if we really need to. And typically are used for less than 2 weeks at a period of time. Okay. Now, the ones we have here are going to include things like dexamethasone and prednisolone, which we've already seen before, right? We talked about that back in ENT, I believe, for a period of time. We also have a couple other ones, things like fluorometholone, loteprednol, rimelexone. Triamcinolone is actually one we'll use for an intravitreal injection most commonly. Now, I noted a few of these here with 3 stars. These are what they call soft steroids. These are kind of later additions to the groups of glucocorticoids used ophthalmically. And these actually have a lower intraocular pressure risk, okay? So, for instance, if I had a test question, I said patient is post-op some sort of eye surgery. You want to prescribe a glucocorticoid for their post-op inflammation. They have a history of glaucoma on both sides of their family. Which of these steroids might be best for that, right? And so you want to pick out the one that's going to be one of those soft steroids that have the little 3 asterisks on these, okay? I hear all the typings. I know that's sticking. Good. Other things, so therapy for dry eyes. Now we're going to get into kind of some miscellaneous ones. Now, most of you probably have never seen these commercials because I'm pretty sure about age most of you know. But anyone know who that guy's name? Ben Stein, absolutely, yeah. So Ben Stein, he had a game show for a period of time. That was kind of funny. Anyway, so therapy for dry eye. So again, he was on all the Visine commercials and things like that, which, you know, Visine, we mentioned, was usually a vasoconstrictor, usually causing constriction those vessels there to decrease the redness. We're looking at things that are actually going to be good for eyes that are dry. So things we can use as replacements for tears. Maybe if tears are not being produced due to, you know, things like, you know, autoimmune conditions, things like that. But a lot of reasons why you can have this precorneal tear film being interrupted. It can be things like blepharitis. You can have chemical burns. So again, we'll oftentimes see the patients, we get calls to the poison center, patients get chemicals in the eyes. It can lead to kind of a prolonged period of time afterwards of dry eye. Other things, anything that's going to be kind of altering the ocular surface or the actual tear composition can affect this, right? And again, as I mentioned, there are lots of systemic conditions that can cause dry eyes. So for instance, things like rheumatoid arthritis, vitamin A deficiency, etc. Okay. So what do we do? We'd like to treat the underlying cause of the dry eyes first, if ever possible, and then we can start to think about things like either chemical or physical interventions here. So from physical intervention standpoint, you can do things like a punctal plug. It actually plugs up the nasolacrimal drain, so that way the tears stick around for longer, whatever they are producing, or you can actually have a surgical cauterization of the duct as well. So I'm going to focus more on the tear substitutes, obviously, and these get used pretty frequently, especially on the inpatient side of things. One of the things you may not consider is if you have a patient, say, in the ICU and they are ventilated. So we put an endotracheal tube down their throat so they can breathe, and they are on heavy sedation. Oftentimes they may have their eyes open or may not be blinking as they normally do, and so they can actually have very dry eyes, and that can actually lead to things like you know, corneal abrasions, can lead to infections. So oftentimes we're using tear replacements on these patients as well, even though they don't necessarily have an ocular problem. We're using it kind of more prophylactically for them. But basically, you're going to find that the stuff that we're using is typically going to be either hypo or isotonic solutions. So again, they should be very similar to the normal tears you'd be producing anyway. And they'll include things like surfactants and thickeners. Now, thickeners being good because just like we talked about ointments being used because they stick around for longer, same thing here, right? So that way the patient's not having to apply it all the time. As a thickener in there, it'll stick around for a little bit longer, okay? So you'll either use things like a balanced salt solution, which again, a solution probably not going to have the best staying power, but good for hydrating the eye. And then we'll have some other products, things like carboxymethylcellulose, hydroxypropyl cellulose, and polyvinyl alcohol. Again, most of these are going to be available over the counter, so patients can buy these no problem. Again, not a lot of issues with them, but always think about things like good hygiene. When they're using good hand hygiene, make sure they're not going to give themselves infections by using this or sharing or anything like that. Now, one thing we can actually use to stimulate new tear production is going to be with an immunomodulator. We have cyclosporine or Restasis. Cyclosporine is actually a good immunosuppressant that we oftentimes will use in cancer treatment, or if you have certain autoimmune conditions, we'll give patients cyclosporine. I'm sorry, not cancer, I should have said transplant is what I meant to say. So if you're trying to prevent the host immune system from fighting off a transplanted organ, cyclosporine can be one of the drugs we'll use for that. But basically what this is doing is if the cause for the dry eye is due to you know, inflammatory sort of response, this can help to tamp that down. It can help to decrease that. You have less T cell activation, and so this will help with increasing tear production, helps to improve vision and comfort for the patient. And so really only indicated, and again, this is prescription only, but for that really chronic dry eye associated with inflammation specifically, okay? Now again, as far as adverse reactions go, ocular burning is pretty frequent, which again, they probably had burning to begin with due to the dry eye, but this can be a common side effect. Foreign body sensation, blurred vision, but again, other than that, pretty well tolerated by most patients. Okay, so any questions on those agents? Moving into talking about glaucoma. Now, anyone know of any maybe non-traditional medicinal products you can use for glaucoma? Marijuana. We're not going to talk about that here. We'll talk about medical marijuana later on in this class, so don't you worry. We'll talk about that extensively, however much you want to talk about it. But just know this is one of those conditions where patients will oftentimes claim some benefit from using medicinal marijuana for their glaucoma. But anyway, glaucoma, otherwise known as ocular hypertension, obviously is going to be characterized by that elevation in the intraocular pressure here, right? What's the problem with having elevated intraocular pressure? Why do we care? Yeah, that extra pressure can compress on the nerve, can cause damage over time, and causing irreversible blindness, right? Now, again, there's open versus closed angle. We're going to be seeing that the drugs focus on the open angle. Closed angle is usually more of a surgical sort of problem we're going to be running into, usually more of an acute sort of issue. Open angle is going to be better for drug therapy, as we're going to see here in a minute. Now, why would the intraocular pressure be high?
Because you can't release aqueous nerve.
Yeah, so there's too much fluid in the eye essentially, right? So again, this fluid is there is causing too much pressure. So what could we do? We could either decrease the production of the actual fluid, or we can help to decrease or increase the elimination of that fluid. Okay. So again, you can see this when we're talking about aqueous humor, and again, there's nothing funny about the subjects. No giggling, please. Humor. Anyway. You're going to find that most of our drugs either target on one of these two mechanisms here. So we're going to see they either work to decrease that aqueous humor production, or they will increase that outflow through that trabecular meshwork, right? Or the canal schlemm, one of my favorite organs. Anyway, that outflow there. And of course, normal pressure, usually 10 to 20 millimeters of mercury here. Anything above that is when we're going to see that ocular hypertension there. And as I mentioned, open-angle glaucoma is the main thing we're going to be focusing on, because again, it's more of a chronic condition. The thing that we're going to be seeing the medications being much better suited for than a closed angle, which is more of a kind of an acute emergent sort of issue. Just kind of show you pictures kind of showing the difference here. And again, we're looking at the fluid flow here. Looking at how it should be flowing, we're going to be looking at things that either decrease that production of the fluid or, again, increase the outflow there. All right, and as I mentioned, goals obviously are trying to preserve the vision as long as we can. And again, just like we're treating normal hypertension, which we're going to talk about in a few lectures here, again, there's going to be a chronic condition. Typically, patients are going to be treated for a good long time here. Because again, as soon as you take the drugs away, what do you think happens? Pressure goes right back up, right? So again, this isn't something like an infectious cause where, again, I can just treat it once for a period of time and then it's going away. This is going to be sticking around for quite a while. Okay, so looking at the groups of drugs we have here, you can reference back to this slide to get your categories, but ones that are going to increase aqueous outflow are going to include our prostaglandins. Very frequently, these are going to be our first-line agents, as you'll see, but again, this is all going to be dependent on the patient, as we'll see in a minute. We're going to have our alpha-adrenergic agonist. Now notice here that you're going to find the alpha-adrenergic agonists are going to be focusing on increasing outflow, but also can work to decrease production. So this one actually provides a little bit of double duty there, which is good. We'll find some cholinergic agents can also be used to help increase outflow. And then as far as decreasing production of the aqueous humor, we're going to find the beta blockers are going to be used here, which are going to be typically second line, maybe first line in some patients. And then we're going to have our carbonic anhydrase inhibitors. Okay. And again, oftentimes you need multiple drugs in order to control that intraocular pressure. So if I had to choose two different categories of drugs, what do you think I would want to consider? Maybe a beta blocker plus maybe a prostaglandin, right? Because again, you want to shoot for our targeting multiple targets here, right? So again, if I can have one drug that focuses on the outflow and one focusing on production, you should get better synergy than if I was using, say, two drugs that worked on the outflow, right? That makes sense? So you can try to use complementary mechanisms, as we'll see here in just a moment. Okay, so looking at the prostaglandins, this is the first group here we'll talk about. Basically, you have prostaglandin receptors that are there within the eye, and by binding to those, it's going to start to increase the outflow of the fluids being produced there in the eye, right? Now the full mechanism, we're not really sure. Some people think it may be due to maybe the ciliary muscle being contracted more, some changes in the trabecular meshwork cells, who really knows? But we do know that it does decrease intraocular pressure, so it's a good drug from that standpoint. The couple drugs we have for this is going to include latanoprost, we have travoprost, bimatoprost, and then tafluprost. Those are the most common prostaglandins you run into from the ocular standpoint. Now, some of the side effects you're going to be seeing with this include things like conjunctival hyperemias. You may see a little bit of increase in redness when applying this, obviously ocular irritation. And this is interesting where you actually have the change in eyelash length and iris color. Does anyone know what else we could use these drugs for potentially? Use it for more aesthetic purposes, right? So I'll show you that in just a second here. But again, you're going to find that the nice thing about this group of drugs is it's very limited systemic side effects. It's not going to be the case with some of the other classes we're going to be looking at, but this is one of the reasons why we like it for a first-line agent. Limited systemic side effects, however, and still effective for lowering that pressure. Now, here's an example looking at some of the changes you can actually find in the iris color itself. So you see this lady, she's probably treated just in one eye with a prostaglandin. So you notice normally she has nice green eyes. They got converted over to a little bit darker brown color. And then looking at Latisse, which is actually a product that is specifically marketed for lengthening of the eyelashes, you can see here the kind of the before and the after, right? So you get these nice long lashes the patient did not have before. So what do you think are some of the problems with this, though? It causes discoloration, right? So if you have nice, pretty blue eyes, they may, and it's not everyone, but they may have irreversible darkening there. They develop brown eyes, right? So again, if someone already has brown eyes to begin with, maybe it won't be such a problem, right? So maybe that's something they're willing to risk potentially. Yes, ma'am.
I was just wondering, like, if that's actually common, because I heard with, like, it happens with the glaucoma because you're putting it directly on the eye, but when you're using Latisse, it's just like the eyelashes, and like it's only a minimal concentration getting into the eye.
Mm-hmm.
So.
Yeah, so theoretically, yes, that should decrease the risk of actually having that occur. However, what I tell my patient who I was maybe prescribing Latisse to, I said, like, there's a 0% chance this is going to affect your eye color. I would tell her that, right? Because again, just like we were saying in EpiBio, like, you never want to be saying that you're 100% certain that something will or will not happen, because again, chances are involved with everything. By putting on the eyelashes directly, you limit that contact with the eye itself. However, there may still be some contact there. There could still be some diffusion that occurs. You may see some changes, right? And again, that's something you have to educate on, because you don't want your patient to come back and be like, I had pretty blue eyes, I was an eye model, and now all of a sudden I got brown eyes. What the heck?
Wait, what's wrong with brown? I was gonna say, yeah, that's pretty. Is that irreversible?
It depends on the kind of the extent of it. In some cases, it may be somewhat reversible, but in some cases, it may be irreversible. The case may be. My wife has brown eyes, so I have nothing against brown eyes. Just saying that I've had green eyes my entire life. If they suddenly change color, I would be a little disconcerted, right? So, but I would have some banging eyelashes. It would look great. But again, it's all a matter of pluses and minuses, okay? But very good point. Thank you for showing that, yes, by applying it just to the eyelashes, you're hopefully going to be limiting that, that actual contact, causing the iris to change color itself, okay? Other things to note here as well, the nice thing about prostaglandins, one-time daily dosing, you actually don't want to exceed that, because in those cases you think more drug is better. What you actually find is it can actually inhibit the intraocular pressure lowering effect, and actually you get the pressure higher than it was with treatment. So again, just one time a day, don't need to increase the dose in those cases there, okay? Up next, you have the beta blocking agents, and again, these are going to be working basically by blocking beta receptors, as you might imagine. Now, what are the main types of beta receptors we run across? Beta 1, beta 2, right? So beta 1 and beta 2 are the main. There's beta 3 as well, but beta 1 and 2 are the main ones we're going to be focusing on here. Now, it's thought the reason why these actually work for glaucoma, we think that by blocking the beta receptors here in the ciliary body, you're going to have less catecholamine activation, right? So less epinephrine, norepi can activate those receptors because they're blocked up now. You're going to see less cyclic AMP actually being produced within those cells, and then that should cause less aqueous humor production to occur here, okay? So again, this beta blocker is only listed second because it is a second-line agent, but it's not going to be working on outflow. It's going to be working more specifically on production here, okay? Now, we're going to cover this much more extensively when we get to the cardio section and talk about beta blockers, but the big delineation between agents is it beta selective or is it beta non-selective? The first group of beta blockers we had were non-selective, meaning they're going to be blocking both beta 1 and beta 2. Beta 1 selective agents are going to preferentially block beta 1, right? Because they're beta 1 selective, as I mentioned. So the one we have here for glaucoma purposes, again, these are ocular products applied directly to the eye. These are not systemic at all. They're going to find betaxolol, which is a beta 1 selective, and they're going to have non-selective agents including cardiolol, timolol, and levobunolol. Again, if you see an olol at the end of a name, typically it's going to be a beta blocker, and that should hold true for almost all the beta blockers, to my knowledge. Now, again, we're going to find that typically the non-selective agents tend to be more efficacious. However, we're going to find more side effects. And so this is probably the first group of ocular drugs we're going to find here that can have pretty profound side effects from a systemic standpoint, as opposed to a lot of the other drugs we've been looking at already, okay? Some people think it's more effective because there's more beta 2 receptors in the eye, but again, you can still get some benefit from using the beta 1 selective agents. Now, when I say selective, does that mean it's going to be 100% selective and never shall a beta 2 receptor interact with? No, again, selectivity is all going to be relative. It all depends on the dose that you have, because I can drive up the dose high enough to where it's going to start to bleed over and interact with beta 1 and beta 2 receptors, as the case may be. Because just know dose selectivity is all going to be related to the dose. Yes, sir.
I get confused.
Yep.
Beta 1 selective selects for beta 1s to be blocked.
Yes. So selectively block beta 1 receptors should preferentially leave beta 2 alone, but if you drive the dose up high enough, you will see some bleed over there, right? So yes, preferentially blocking beta 1. Thank you. Now, adverse reactions, because we worry about the nasolacrimal drainage, looking to see some systemic effects here, we're going to find that beta blockers do what to the heart rate? Typically slow it down by interacting with which beta receptor? Beta 1, right? Beta 1's on the heart predominantly, so by slowing that down, by blocking those receptors there, you're going to be seeing things like worsening heart failure, right? These are typically older patients you're going to be treating, so they already have left ejection fraction impairment. This is going to worsen that, right? It's going to cause bradycardia, cause heart block. And the other big thing you can see with this is it can actually cause increased airway resistance. Now, why does anyone think that's the case?
Beta 2 receptors.
Yeah, so beta 2 receptors are going to be lining the airway, and typically when you activate those receptors, what does beta 2 do? Actually causes bronchodilation, right? Remember, alpha 1 typically causes constriction of smooth muscle. Beta 2 causes relaxation. The big places it's going to do that is within the lungs. So if I have a non-selective beta blocker on board, say I have a patient who's being treated cardiolol and they have a history of asthma, so that reactive airway disease already, this can induce an asthma attack in those patients because you're going to find those beta 2 receptors are going to be blocked. So instead of causing relaxation, it's going to cause constriction of those bronchial smooth muscles, impeding airflow. Patient's not going to oxygenate as well. Make sense? So this is why you got to be really careful with beta 2 blockers, or I'm sorry, non-selective beta blockers that are blocking beta 2 receptors in asthmatic patients. Okay, it's going to be an easy board type question that may come across. It's going to be one of those things that I'll throw in on the questions about beta blockers pretty frequently. Say, hey, they got asthma. What are you going to use next, right? Or it's going to be the best drug for this patient based on X, Y, and Z. So I mentioned beta 1 primarily in the heart. It's going to be for that contractility and heart rate. So you're going to expect that to lower if I have either beta 1 selective or non-selective agent. And the beta 2, you should see that's going to be more responsible for that bronchodilation, right? So again, if I had a beta 1 selective agent, right, like betaxolol, is that going to be able to slow down heart rate? Absolutely, right? Because again, you're going to find it's going to be so beta 1 selective and beta 1's predominantly on the heart. However, which would be better for an asthmatic patient? Beta 1 selective agent, okay? And we're going to cover this in cardio as well, so we're going to hammer it there additionally, so just going to keep that in the back of your mind.
You said these are ophthalmic solutions, right?
Mm-hmm.
And they can still have these.
They can still do that, right? Because again, do that nasolacrimal drainage, you're bypassing the first pass effect. They can get systemic and cause systemic effects, right? So again, and as patients get older, they typically lose more of that hemodynamic reserve, so those effects are going to be more pronounced. If I had a relatively young patient, had a good cardiovascular system, they could probably overcome that. They can probably, you know, compensate for that and not really have any issues. The asthma thing might still be a problem, but you know, if they already have existing heart failure, you know, bradycardia, things like that, that's just going to worsen that potentially. Okay. Okay. So again, just note that non-selective ones are going to block both. Beta 1 selective agents are primarily just going to block beta 1 receptors. Those are going to be better for patients who have a history of reactive airway disease, history of asthma. Okay. Up next, we have the alpha adrenergic agonists, and so these are typically going to actually activate alpha 2 receptors, but when applied directly to the eye, you're going to find they have some good effects on alpha 1 as well. Basically, though, what we're going to find is that with the alpha 2 effects, this actually helps to decrease catecholamine release. If you guys remember back to physio, we talked about autoreceptors. Remember, autoreceptors shut off release of more catecholamines in this case. So with alpha 2 was that receptor there. So in this case, we actually have an alpha 2 agonist. Will bind to that receptor, activate it, and cause less norepinephrine and epinephrine to be released onto the eyes. So when you do that, that actually helps to affect both aqueous humor production. That should go down, and it will increase the outflow to the trabecular meshwork. Okay, so again, you kind of get dual activity here. And there's two main ones we're going to run into, including aproclonidine and then brimonidine. Okay, now we do worry about in some patients, if these were to get systemic, this can actually cause you know, some CNS effects as well, which is oftentimes what you see. If anyone's ever heard of the drug clonidine before, I've ever mentioned that. This is actually in that same family, right? And again, anyone who's familiar with clonidine, one of the things you can actually use it for is ADHD. Kind of slow the whole system down to some degree by decreasing that sympathetic outflow. And so one of the things you can see with this is that these drugs can have the same effects should they get systemic. The nice thing about them is that these are actually highly ionized at physiologic pH. So what do you think that means as far as absorption goes into the CNS? If they're ionized, they should do what? They're not going to be able to, right? Remember how we talked about second generation antihistamines? They have a permanent charge on them. They're highly ionized. They can't cross that blood-brain barrier. Same thing happens here, especially with aproclonidine. That has it's highly ionized at physiologic pH. Is unable. Remember Henderson-Hasselbalch? Can we draw out the whole thing again? I'm not going to do that to you, but just know that because of the physiologic pH, the drug is a very highly ionized, cannot cross the blood-brain barrier, it's just going to bounce right off of it. That helps to limit those side effects. The problem, though, is if you have especially young patients or potentially very old patients, you can end up running into some issues where, especially for kids less than 2, it's contraindicated because you can end up seeing CNS depression and apnea occur here, right? So you got to be very careful, especially at clonidine in kids. Like, you just want to avoid it typically. Okay. Next up, we have carbonic anhydrase inhibitors. So this one is going to be, we're inhibiting the enzyme, carbonic anhydrase. You guys remember that enzyme? What does that do? Yeah, it will take carbon dioxide and water, convert it into, yeah, and turn it into bicarbonate or carbonic acid essentially, right? And that hydrogen ion can fall off. And it can interconvert that, right? So you can take carbonic acid and convert it to CO2 and water and vice versa, right? So one of the things you find is that aqueous humor production is going to be mediated a lot through the effects of carbonic anhydrase. If you inhibit that enzyme system, you end up decreasing the amount of aqueous humor being produced, okay? So just know ultimately that's what's going to be happening here is you're decreasing aqueous humor production by inhibiting carbonic anhydrase. Two drugs you see here include dorzolamide and brinzolamide, and for the most part, not nearly as effective as you're going to see with things like the prostaglandins or beta blockers. This is a great adjunctive agent, so you can add it on to one of those other groups, and you'll oftentimes see combination products usually include one of these carbonic anhydrase inhibitors, as the case may be. Again, pretty well tolerated, but you're going to find some bitter taste. Again, due to that drainage, you're also going to find some stinging after administration, which makes it less tolerable to most patients. But again, if you need something else to add on, this may be a good option for them. This is one of the least used classes for glaucoma. These are going to be our cholinergic agonists. And so if you remember, muscarinic receptors, when activated in the eye, what typically occurs? You're going to see meiosis, right? Remember we talked about the dumbbells. What is the M in dumbbells? Meiosis, right? So you're going to cause that circular muscle there to constrict. You're going to be finding that by causing that ciliary muscle contraction, it's going to help to facilitate that further outflow. So what do you think the problem with using something like this is? Yeah, the vision's not going to be great, right? It's going to affect accommodation. It's going to be affecting the vision. So, especially with younger patients who, maybe have full vision, this is not going to be good for them. This may be someone who's maybe more progressive and maybe they already have some visual impairment. This may be a better option, but typically this is going to be kind of third, fourth line sort of agent to add on after prostaglandins and beta blockers, etc. Right? A couple of drugs, and sometimes I mentioned these here predominantly because you're going to find these sometimes used in ophthalmic surgery. So you have things like acetylcholine, which makes sense that it causes it's a cholinergic agonist because it's acetylcholine, right? You have carbachol and then pilocarpine. As I mentioned, due to side effects, you're going to find pretty poor compliance. Again, you can end up finding that really fixed small pupils, myopia, visual disturbance. Those are the big things that kind of prevent patients from really wanting to keep using these drugs here. Okay. As I mentioned, combination products are always going to be good because that helps with what? Compliance, right? So not only do you have the fact that patients are having to apply multiple drops, but it takes time, right? We mentioned every time you put an eye drop in, you want to sit there and hold the lacrimal duct closed for 2 to 3 minutes. You need to give it time to apply each of those drops. So if the patient's on 2 or 3 drugs, it's going to be pretty time consuming. So compliance is going to go down. This is why we like to use combination products whenever possible. So for instance, you could use something like a combination of brimonidine plus timolol, which again, you have alpha adrenergic agonist plus a beta blocker, using synergistic mechanisms here to try to get better effects than with either one by themselves, okay? Now, who to treat? The question is, do you just sit there and kind of watch and see kind of how their visual acuity changes over time, seeing how their visual field will develop? Usually people with more risk factors, a strong family history of it, you're going to try to treat them earlier because you already know they are going to be a bigger risk for that. Otherwise, sometimes you're going to be monitoring until you start to see some of those glaucomatous changes occurring. And again, predominantly you're going to be starting either with a prostaglandin or a beta blocker. Okay, so if I said, hey, you have a patient who has asthma, what type of drug would you want to start them on? Prostaglandin is pretty safe. What else could I use? A beta-1 selective blocker. So I could use something like Betaxolol, or I could use something like latanoprost. Either one of those would be correct answers in that situation there, right? So that patient comes in, they're very concerned about, they have these nice, pretty baby blue eyes. They're really worried about eye color changes. What would be a good option for them? Well, not a prostaglandin, right? A beta blocker is going to be a better option for those patients, right? So those are things you have to consider as far as what's going to be really first line for your particular patient there, right? And sometimes you'll actually try the drug just in one eye just to see how the patient tolerates it. And then if it's effective, you can try using it in both eyes after that point. And typically you want to get about a 20 to 30% drop in intraocular pressure. If that's not achieved with one drug, then you'll add on another for a period of time. Okay, just a few more kind of miscellaneous drugs here. We have ocular anesthetics. When are we going to use these? Typically for procedures or exams that you need to perform on the eye. We don't use these commonly for actual pain relief, as we'll see why in a few minutes. We've covered that already. I remember when we did the ophtho case a couple weeks ago. But basically the way these anesthetics are going to work is they actually will inhibit action potential propagation. They do that by blocking sodium channel influx. If you remember how we actually have action potentials propagating down the neuron, they do that by sodium channels kind of going down the nerve. By blocking those up, you kind of halt the action potential and prevent it from getting propagated any further at that point. So that's why you cause cause the actual anesthesia, because those signals of sensation are not going to be actually traveling up to the brain at that point. Okay, the two big ones we use most frequently are going to include tetracaine and then proparacaine. These are good for using for like kind of short-term procedures like foreign body removal, superficial corneal surgery, tonometry. All these things are going to be good for those cases. However, we do not write prescriptions for patients for these. We do not let them take them home. Why is that?
Can't feel to get something in their eye.
Yeah, so if they're going to be using this or self-medicating with this, they're just going to be like, well, I don't feel anything. My eye pain's all gone. It must be better, right? Not realizing they may have a foreign body. They lose their blink reflex, and so that may lead to further eye drying and further corneal abrasion. So because of that, we do not write prescription for these. We keep them just for use in the offices, right? Is anyone familiar with what the first topical anesthetic was we ever discovered as a human race? Cocaine was actually the first one. We actually used cocaine in a lot for. I know I always go back to cocaine, huh? Not a couple of years, but just kidding. Anyway, so the point being is that it was used for a lot of ENT procedures for a long time. Not only was it a good anesthetic, it was a good vasoconstrictor, so it helped kind of keeping the surgical field pretty clean. But one of the interesting things is that the smokable form of cocaine is called crack, for those of you who are unfamiliar, which I hope is everybody. But for your information. So the problem with that, though, is you can actually have patients who will come in, we call this crack eye, where basically when they're smoking the cocaine, the vapors can actually go up and affect the eye. And as we mentioned, cocaine was the first topical anesthetic we had, and so they actually lose that blink reflex. So they can sit there and they have these, no urge to blink, and the eye gets dried out, and they get these corneal abrasions that develop. So we call that crack eye. If you ever hear that, again, good thing to ask your patients. Hey, do you use any illicit substances? Hopefully they're honest with you, and they'll say, oh yeah, I smoke crack 3 times a week. I don't know, maybe they got arrested and they find the pipe in their pocket or something like that. Maybe there's some clue that yes, they may be using that. But anyway, again, for anesthetics, ocular anesthetics, do not write prescription for these. Just keep them in the office. We also have some cycloplegic agents. Anyone know what that term means? Yeah, so plegic means it's going to be causing paralysis. So basically, it's going to be dilating the eyes, and can help us to dilate them to get better exams, do better fundoscopic exams, things like that, right? Typically, most often we're going to be using antimuscarinics here, because as we mentioned, we saw earlier that cholinergic agents will cause miosis. We want something to cause mydriasis. So most frequently we have antimuscarinics, basically by blocking muscarinic receptors, should cause mydriasis, right? So we said blind as a bat was a mnemonic, a part of the mnemonic for antimuscarinics. Same thing applies to this, right? So we have atropine. Again, we're going to run across atropine, especially when you get to like cardiology stuff or like emergency medicine stuff. That's the prototypical antimuscarinic. It's going to block those receptors and cause mydriasis. Other ones that we have that will specifically be used in ocular use as well is going to include cyclopentolate and then tropicamide, right? Again, they all work very well. They'll dilate the eye. The problem is when you have eyes dilated with an antimuscarinic is they usually like to stay pretty wide open for a while there. So you're going to see a lot of blurred vision, a lot of photosensitivity. So these are going to be the things where they say, hey, got my eyes dilated and have to wear the funny glasses all day long. This probably was an antimuscarinic because you're going to find that the combination is not going to work very well. That would be very photosensitive for several hours after the exams actually occurred. People would like to use a shorter acting agent is going to be a sympathomimetic, right? Sympathomimetic just means it's mimicking the sympathetic nervous system. So these are going to be things that are going to work on things like the alpha receptors in the eye, right? And alpha receptors typically cause mydriasis, as you see by pulling on those radial muscles within the eye itself, right? So typically patients remain more light sensitive after use of a sympathomimetic. So these are better for patients who maybe need to go to work after their eye exam or something like that. And the main ones we're going to use include phenylephrine. That's probably the only one that we're going to be using clinically for the most part. There are other ones, but phenylephrine's the common one. Now, what did I say about phenylephrine before? Not a very good drug, right? That was for like nasal decongestant use. That was more for over-the-counter use. If you're using it for like an exam here, we're actually directly applying it to the patients. Very good mydriatic agent. Very good for getting your exam done and leaving the patient with somewhat functional eyes after the fact. Okay. Okay. And last thing, one of the last things we'll talk about is fluorescein. What do you use fluorescein for? Stain it into the eyes. That way we can actually look for things like corneal abrasions and whatnot. Again, make sure you spell it F-L-U. I mentioned to some of the students during PD lab day that I had one doc who was literally delayed by 10 minutes because he could not figure out how to spell fluorescein. He was typing into the computer system F-L-O, 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 and he could not find the fluorescein to save his life. I said F-L-U, and he looked at it, oh, there it is, and boop, and picked it, but delays him 10 minutes, right? And that's more patients you could be seeing during that time. So again, just remember the spelling sometimes is important. But basically, yeah, so it's going to stain the eyes, it's going to be able to be picked up by those Woods lamps, be able to look for things like corneal abrasions and whatnot. It's going to be very useful for that. Usually not a lot of problems with this one, but most often when you're doing these exams, you'll probably apply an anesthetic as well anyway. So you'll probably do some tetracaine. That helps to limit some of the stinging you're going to get with this. And typically this comes as a strip. You can just dip the strip down into the cul-de-sac there, and that's going to help to, it'll then kind of wash over the eye as the patient blinks, and that will get better than having to like dab it right on the eye itself. So any questions on ophthalmology stuff? Okay. You may think you're done. I would like to start the next section because, again, I had to kind of heavy load this one. So